Okay, so we'll start the next part of the VSV session. So here is an interesting ligament. Okay, most commonly missed injury in the foot. Okay, so you should know about this ligament, which extends from the medial cuneiform. So this is medial cuneiform bone. This is medial cuneiform bone, and what you see here is the metatarsal, metatarsal bone, second metatarsal bone. So you have a ligament which extends from the medial cuneiform to the base of the second metatarsal. Okay, so this ligament is called as a Lisfranc ligament. This ligament is called as what? Lisfranc ligament. So Lisfranc ligament basically connects the medial cuneiform with the second metatarsal base, and because of inversion injuries to the foot. Okay, because of inversion injuries to the foot, inversion injuries to the foot. Okay, so cause injury to this ligament where there is a traumatic disruption happens between the medial cuneiform and the second metatarsal, leading to widening of the interval between them. Okay, so whenever you see this patient, okay, stress views will help in bringing out this injury. Stress views are needed to bring out the subtle injuries, and if the patient has gotten Lisfranc injury, then it is better to treat with an open reduction internal fixation or by doing an arthrodesis. So Lisfranc ligament is very, very important. You should know where the Lisfranc ligament starts and where it ends. Lisfranc ligament is seen from the medial cuneiform to the second metatarsal base, and there is a joint called as Lisfranc joint. So what is this Lisfranc joint? The joint between the tarsal and the metatarsal region. So this joint between the tarsal and the metatarsal region is called as a Lisfranc joint. So this is called as a Lisfranc joint. So this is called as what? This is called as a Lisfranc joint. Okay, so remember the joint between the tarsal and the metatarsal. The tarso metatarsal joint is called as an Lisfranc joint. Okay, so Lisfranc injuries are very, very important injuries in the foot which are commonly missed. Now they are giving a clinical test here where the patient keeps his forearm behind his back, okay, and is trying to resist the examiner's hand. Okay, so this kind of test is called as an Gerber lift off test, which is used to check a muscle called as subscapularis muscle, which is used to check a muscle called as what? Subscapularis muscle. Okay, so to know about this muscle, I hope you all know there is a bone called as humerus. It has got greater tubercle, it has got the shaft, and has got a lesser tubercle here. And we have a bone here called as scapula. So if you see scapula, you see this hook-like process. Can anybody tell me what is this hook-like process represents? Can anybody tell me what is this hook-like process represents? Yes. So hook-like process. Yes, guys. So the hook-like process represents the hook-like process in the scapula represents an important process called as a coracoid process. So this is called as what? Coracoid process. So once you see the coracoid process, you are seeing this fossa which is called as a subscapular fossa. So this fossa will be subscapular fossa. This fossa will be subscapular fossa. And from the subscapular fossa, a muscle arises and gets attached to this tubercle. So this muscle which is attached to this tubercle is called as subscapularis muscle. And what is this tubercle? This tubercle is called as a lesser tubercle. This is called as a lesser tubercle. So the subscapular muscle arises from the subscapularis fossa, and it is attached to the lesser tubercle, and the subscapularis muscle is supplied by upper and lower subscapular nerve. It is supplied by upper and lower subscapular nerve. It is supplied by upper and lower subscapular nerve, and this is supplied by upper and lower subscapular nerve. And what action does it do? It causes internal rotation of the humerus. It causes internal rotation of the shoulder joint. Internal rotation of the shoulder joint is mainly done by subscapularis. Internal rotation of the shoulder joint is mainly done by subscapularis. Okay, subscapularis. Many times subscapularis injuries are missed. Subscapularis tendon. That is why subscapularis tendon is also called as a forgotten tendon. It is also called as an forgotten tendon. It is also called as an forgotten tendon. It is also called as what? Forgotten tendon. Okay. Now I hope you know this is lesser tubercle. You are seeing lesser tubercle, and this is called as a greater tubercle. This is called as a greater tubercle, and there is a muscle which is attached to the greater tubercle from the supraspinous fossa like this. From the supraspinous fossa like this. The muscle which is attached to the greater tubercle coming from the supraspinous fossa is nothing but the supraspinatus muscle. So this muscle is supraspinatus muscle, supraspinatus muscle, supraspinatus muscle. Now you see an interval between the supraspinatus muscle and the subscapularis muscle. The interval which you see between these two muscles is called as an rotator interval. Is called as an rotator interval. Is called as an what? Rotator interval. All these are very very important subtle points were not routinely given in our books. So please go through this. So you got subscapularis muscle attached to the lesser tubercle. You got supraspinatus muscle getting inserted into the greater tubercle. In between these two muscles, you have a space which is called as an rotator interval, which is called as a rotator interval. Now, whenever there is a subscapularis muscle injury, you can diagnose subscapularis muscle injury by using this test called as a Gerber lift-off test. The other tests which are used in subscapular injuries are belly press test. Belly press test. Belly press test is used in is an another test which is used to diagnose whether there is a subscapularis injury is there or not. The most common tendon which is injured, the most common rotator cuff muscle, the most common rotator cuff muscle, the most common rotator cuff muscle injured is not subscapularis. It is supraspinatus. It is supraspinatus. It is supraspinatus. The most common rotator cuff muscle injured is supraspinatus. So you should know the name of the test for these muscles. So the tests which are used for the supraspinatus injury are, one is called as an Jobs supraspinatus test. Jobs supraspinatus test. Jobs supraspinatus test. Then there is a test called as drop arm test. Then there is a test called as drop arm test. Then there is a test called as drop arm test. So there are certain tests called as Hawkin Kennedy test. Hawkin Kennedy test. So these are all tests used to test the supraspinatus muscle. Okay, used to test the supraspinatus muscle. So Job supraspinatus test, drop arm test, Hawkin Kennedy test are certain tests which are used to test the supraspinatus muscle. Used to test the supraspinatus muscle. So important tendon is supraspinatus, forgotten tendon is subscapularis. Forgotten tendon is subscapularis. Okay. So with this note, we'll move to the next question. Again, a very very important question. Okay. So to understand this lesion, I want you to simply understand one cross-sectional diagram of the humerus. Okay. So if you see the shoulder joint, if you see the shoulder joint, I'm just making a cross section of the shoulder joint. So this cavity, what you see here is the glenoid cavity. As you all know, the glenoid cavity is a very, very shallow cavity. It's a very, very shallow cavity. And this shallow cavity is deepened by the attachment of a fibrocartilaginous structure to its rim. And this fibrocartilaginous structure, which is attached to the rim of the glenoid cavity, is called as a glenoid labrum. So, what is the structure which I have marked here? This is glenoid labrum. This is called as what? Glenoid labrum. This is called as glenoid labrum. Now, this is the anterior portion of the scapula. This is the posterior portion of the scapula. Now you see a bone which articulates with the glenoid cavity. The bone which articulates with the glenoid cavity is nothing but the head of the humerus. Is nothing but the head of the humerus. So what is this? This is head of humerus. This is head of humerus. So they form a joint here. I hope you all know what is this joint called as. This joint represents a shoulder joint. This joint represents the shoulder joint. Now what is the problem with the shoulder joint? Shoulder joint is a mobile joint. Because of its increased mobility, there is high chances for it to get dislocate. So most common joint to get dislocate in the body, most common joint to get dislocate in the body is shoulder joint. Most common joint to get dislocate in the body is shoulder joint. Is shoulder joint. Okay. So shoulder joint dislocation can happen in three ways. It can be an anterior shoulder dislocation, it can be an posterior shoulder dislocation, or it can be an inferior shoulder dislocation, or it can be an inferior shoulder dislocation. It can be an anterior shoulder dislocation, it can be an posterior shoulder dislocation, or it can be an inferior shoulder dislocation. So what do you mean by an anterior shoulder dislocation? So the humerus slips anteriorly and it slips antero-inferiorly. So this is called as an anterior dislocation. So whenever there is an anterior dislocation, there are various clinical tests like Dewgau's test. There are various tests like Callaway's test. There are tests like Callaway's test. There are tests like Hamilton Ruler's test. There are tests like Hamilton Ruler test. There are tests like Hamilton Ruler test. So there are a lot of clinical tests to diagnose anterior shoulder dislocation. And whenever the shoulder dislocates anteriorly, imagine what happens when it dislocates anteriorly. There is a high probability to injure this structure, which is called as the labrum, which is called as the glenoid labrum. And which portion of the glenoid labrum is injured? It is the anterior portion of the glenoid labrum is injured. So if you see the dislocated shoulder, so you can see the posterior labrum is intact. The posterior labrum is intact, whereas the anterior labrum is torn. The anterior labrum is torn, and the shoulder, when it slipped anteriorly, the humerus impinges on the anterior glenoid, and in the humerus, a small defect is created. In the humerus, a small defect is created. So, because of shoulder dislocation, two pathogenesis happens here. Two pathologies happens here. So you have a torn labrum. So glenoidal labrum, torn glenoidal labrum. And which portion of the torn glenoidal labrum? It is the antero-inferior portion of the glenoidal labrum is torn. Antero-inferior portion of the glenoidal labrum is torn. This is called as a Banker's lesion. This is called as an Banker's lesion. This is called as a Banker's lesion. So when the head displaces anteriorly, the humeral head is like an eggshell. It is very soft. When it impinges on the anterior portion of the anterior portion of the glenoidal rim, a defect is created in the humeral head, and this defect is called as an Hill-Sachs defect. This defect is called as what? Hill-Sachs defect. Hill-Sachs defect is present on the posterior part of the humeral head. Posterior portion of the humeral head, this defect is seen. Okay, so this is called as an Hill-Sachs defect. This is called as an Hill-Sachs defect. So remember, when the shoulder dislocates, so the shoulder has got so a lot of pathogenesis that happens. One is it causes the tear of glenoidal labrum, which is called as a Banker's lesion, and there is a depression which is created in the posterior part of the humeral head, which is called as a Hill-Sachs defect. All are very, very important things to be noted here. Now the picture shows a tear in the anterior-inferior glenoidal labrum, which is called as an Banker's lesion, which is called as an Banker's lesion, which is called as a Banker's lesion. Okay, so if there is a Banker's lesion, then you need to repair the Banker's lesion to prevent recurrent dislocation. To prevent recurrent dislocation. To prevent recurrent dislocations. Okay, so yesterday we saw a surgery which is used to treat the bony Banker's lesion, where there is a fracture here like this. So this is called as a bony Banker's lesion. A chronic bony Banker's lesion can be treated by a surgery called as Latharget procedure. Can be treated by a procedure called as Latharget procedure. Okay, can be treated by a procedure called as Latharget procedure. Okay, so Banker's repair can be done to repair the soft tissue Banket. Bony Banket can be treated by a procedure called as Latharget procedure, treated by procedure called as Latharget procedure. Okay, so these are all very, very important aspects of Banker's lesion. Shoulder dislocation, the most common type is anterior shoulder dislocation. So please remember, anterior shoulder dislocation is the most common type, so please do remember. And posterior shoulder dislocation is the next most common type, and you get a classical sign, radiological sign in posterior shoulder dislocation, which is called as an light bulb sign. So there is a sign called as light bulb sign, which is seen in posterior shoulder dislocation, Okay, so next test or next important sign is this one. So this sign is called as an Galeazzi sign. This sign is called as an Galeazzi sign, where if you observe the child's knee, okay, so when they flex the hip, you can see there is a difference in the levels of the knee. You can see the difference in the levels of the knee. This side, the knee looks shorter. The knee looks shorter here, okay, compared to the other side. This sign is called as an Galeazzi sign, which is also called as an Alice sign, which is also called as an Alice sign, which is also called as an Alice sign. Galeazzi sign was found by an Italy orthopedic surgeon, which is he is called as an Galeazzi. His name is Galeazzi. Okay, his name is Galeazzi. Okay, so he is an Italian orthopedic surgeon who discovered this sign. So that is why it is called as an Galeazzi sign. So this is a sign which is used in DDH. Okay, so whenever the patient has got dislocation of the hip, the patient will have shortening of the hip on that side. So we have seen lot of signs for the congenital dislocation of the DDH in the morning. So we saw Barlow test. We saw Barlow test. Yes, we saw Barlow test. We saw Ortolani test. We saw Ortolani test. Yes, we saw Ortolani test. Now we are seeing a test called as Galeazzi test. Galeazzi test. There are certain other tests like Clisic test. Clisic test is also used for DDH. Clisic test is also used for DDH. When a patient has got DDH, okay, unilateral DDH, the patient will have Trendelenburg gait. Trendelenburg gait. The patient will have Trendelenburg gait. Okay, the patient will have Trendelenburg gait. If it is in bilateral DDH, the patient will have waddling gait. The patient will come to you with waddling gait. The patient with bilateral DDH will have increased lumbar lordosis. So in them, the lumbar lordosis is increased. Lumbar lordosis is increased. So all these are clinical features, clinical signs, which will tell you that the patient has got an congenital dislocation of hip or developmental dislocation of the hip. Okay, so based on these tests, we can find out that the patient has got a DDH or not. Now, this Galeazzi sign or Alice sign is present only in this condition or it is present in other condition also. So, there are certain other conditions, or if you take the differential diagnosis for the Galeazzi sign, it can be also seen in certain other conditions like proximal, proximal femoral focal deficiencies. There is a condition called as proximal femoral focal deficiencies, neglected hip dislocations, neglected hip dislocations, neglected hip dislocations, neglected hip dislocations. Okay, late stages of Tom Smith arthritis, late stages of Tom Smith arthritis, late stages of Tom Smith arthritis, femur fractures, femur fractures. In all these conditions, there can be shortening of the thigh on the affected side, resulting in a positive Galeazzi sign or Alice sign. Okay, so all these are important differential diagnosis for Galeazzi sign. Okay, so what is Galeazzi sign? So when you keep the hip and the knee flexed, if one knee is shorter compared to the other knee, then that is called as in Galeazzi sign or Alice sign. So this sign is not only seen in DDH, it is also seen in other conditions like the proximal femoral focal deficiencies, neglected hip dislocations, late Tom Smith arthritis or femur fractures. Okay, so please make a note of all these things are important points, and these are all the clinical tests which are seen in DDH: Barlow's test, Ortolani test, Galeazzi test, Clisic test. Clisic test is used in bilateral DDH. Bilateral DDH is usually diagnosed by this test called as Clisic test. Okay, the patient can present to you with a Trendelenburg gait or a waddling gait, and they can also have an increased lumbar lordosis. So very important points around developmental dysplasia of the hip. Very important point around the developmental dysplasia of the hip. Okay, so with this note, we'll move to the next question. So this is a surgical procedure what they have shown here. So most commonly, if they show a patella X-ray, patella picture, and if they show wires and K-wires around that, then the most common technique which is used is tension band wiring. Okay, so actually if they use only SS wire. So this is two kinds of wires they have used. What you see here is an SS wire, and what you see here is a K wire. Okay, K wire. Okay, so to treat the patella fracture, if you use only SS wire, only SS wires, then that is called as an tension band wiring. So to treat the patella fracture, if you use SS wires plus K wires, then that is called as a modified tension band wiring. Then that is called as what? Modified tension band wiring. Now, what is the principle of tension band wiring? Tension band wiring base works on the principle that here the tensile forces are converted into an compression forces. Okay, so the tensile forces are converted into an compression forces. So for any fracture, if you want to apply this principle, so it requires two sides. Okay, so to understand this, we'll just make a simple schematic diagram so that you can easily understand this. So now what you see here is the femur bone. What you see here is the tibia bone. You can see the tibial tuberosity there. And what you see here is the patella bone. And this patella bone is attached above to a muscle called as quadriceps muscle. It is attached above to a muscle called as what? Quadriceps muscle. So there is a muscle which is attached here called as quadriceps muscle, and there is a ligament which is attached here called as the ligamentum patellae. Okay, so if a fracture happens, if a fracture happens here in the patella, now the patella tends to open up because of the pull of the quadriceps muscle on one side and because of the pull of the ligamentum patellae on the other side. So normally what happens is a simple transverse fracture patella will end up like this. A simple transverse fracture of patella will end up like this. Okay, will end up like this. So this is how a patella fracture, a simple transverse fracture ends up like this. Now, if you see the patella, you got two surfaces here. The surface what you see here is a compressive surface, is called as a compressive surface. The surface what you see here is a tensile surface, is called as a tensile surface. Okay, it is because of the pull of the muscles and the ligament, the tensile surface is opening out and the fracture is opening out. So you fix this fracture by using this technique called as tension band wire technique. So thereby this tensile forces which are acting here will be converted into a compressive force, and the fracture will be kept in position, So always remember, if a tensile force and a compressive force are there, and if the fracture is a transverse fracture, then you can apply this principle called as tension band wiring. Now, tension band wiring is not only used in patella fractures, it is used in number of other fractures like olecranon fractures. It can be used in medial malleolus fractures also. So these are certain indications where tension band principle can be applied. So main prerequisite is there must be a transverse fracture, there must be a compressive set, and there must be a tensile set. These are all the prerequisites for tension band principle to work. So for patella, the investigation or the treatment of choice is tension band wiring. Okay. So with this note, we'll move to the next clinical image. So they have given an instrument or an implant based question. Here you can see there is a fracture here. So you can see there is a fracture here. Here you can see the bone is cut here. So here you can see the bone is cut here. So they have done a procedure called as corticotomy. They have done a procedure called as corticotomy, and they put some rings and they are doing this surgery. And this surgery is called as Ilizarov surgery. This surgery or this construct is called as an Ilizarov construct. Okay, this Ilizarov is discovered by a Russian surgeon. Okay, is discovered by a Russian surgeon called as Gavril Ilizarov. Is discovered by a Russian surgeon called as Gavril Ilizarov. Okay, this Gavril Ilizarov is a person who was involved in lot of military works. Okay, he was a military surgeon. So when he saw the patient in military field, lot of wound were contaminated, Lot of wound went in for non-union. So to treat the infected non-unions, he mainly discovered this ring, which is called as an Elizarov ring. Elizarov ring works on a principle called as distraction osteogenesis. It works on a principle called as distraction osteogenesis. Now, what is distraction osteogenesis? When you slowly increase the tension in the bone, there will be generation of the new bone. Okay, so what it does is, okay, so when there is a non-union here, okay, when there is a non-union here, when there is a non-union here, or when there is an infection here, when the bone is not uniting, so he made a small corticotomy there, and he started to mobilizing this bone. Gradually, this bone goes and fuses with the bone below, and here the new bone is formed. Here, new bone is formed. Here, new bone is formed. So, this principle is called as a distraction osteogenesis. This principle is called as what? Distraction osteogenesis. So, it is the generation of new bone by gradually increasing in the tension of the bone is called as distraction osteogenesis. Remember, just you know the principle name, that is more than enough. Okay, so Elizarov works on the principle of distraction osteogenesis. Elizarov was initially used to treat the infected non-unions. So the indications are much more for Elizarov. So you can use Elizarov for treating non-unions of the bone. It can be used to treat the infection of the bone. It can be used to treat the infection of the bone. Okay, it is used to treat the infection of the bone. It is used to treat the deformities of the bone. It compartmental pressure, which further increases the compartmental pressure and further provoking the ischemia and further provoking the ischemia. So whenever the muscles went in for ischemia, then it results in permanent contracture, which is called as an Boltzmann ischemic contracture. And the common muscle that is involved in the forearm is the flexor digitorum profundus muscle. Is the flexor digitorum profundus muscle, which is the most commonly affected muscle in Boltzmann ischemic contracture. And the nerve which is commonly affected in Boltzmann ischemic contracture is median nerve. The nerve which is commonly affected in Boltzmann ischemic contracture is median nerve. Okay, whenever a patient has got some Boltzmann ischemic contracture, if it is picked up at an early stage, if it is picked up at an early stage, okay, you can treat it with stretching exercises. You can treat with stretching exercises. Early mild varieties you can treat with stretching exercises. Okay, and you can give certain splints which is called a stern buckler splint, which are called a stern buckler splint. Okay, so the splint which is used in the treatment of Boltzmann ischemic contracture is called as a turn buckler splint. Turn buckler splint can be used. Turn buckler splint can be used. And if the patient comes to you with an late uh, or an severe disease or with a severe disease, then it requires debridement and tendon transfer procedures. 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 Okay, so Boltzmann ischemic contracture is a very very dreadful complication of a supracondylar humerus fracture. If it is missed, then it can cause severe deformity in the patient. It can cause severe deformity in the patient. So very very important splint, turn buckler splint. Turn buckler splint. Most common affected muscle is flexor digitorum profundus. Most common nerve involved is median nerve. Most common nerve involved is median nerve. Okay, so these are all very very important things to be noted in Boltzmann ischemic contracture. Okay, so with this note, we'll move to the next clinical picture. So it is an X-ray picture which gives the appearance of a rugby jersey. Okay, so these jerseys are usually worn in the players who plays rugby. So this looks like a rugby jersey. So here you can see the end plates are sclerotic. Here what you see here is these are the end plates. They are the end plates are sclerotic whereas the center of the vertebra are lytic. So center of the vertebra are lytic. So when you have an alternate sclerotic and lytic pattern, it gives an rugger jersey spine appearance, which is commonly seen in a condition called as hyperparathyroidism. Hyperparathyroidism secondary hyperparathyroidism, mainly due to a chronic kidney disease, mainly due to a chronic kidney disease. Okay, so if you need to understand the secondary hyperparathyroidism due to a chronic kidney disease, you must understand one simple concept. Okay, so renal or kidney is one of the main source for vitamin D activation. Vitamin D activation, kidney is very very important. Kidney is very very important. Okay, so whenever there is a chronic kidney disease, vitamin D is synthesized in a very low manner. Vitamin D is synthesized in a very low manner. When there is a chronic kidney disease, calcium is not reabsorbed. Calcium is not reabsorbed. Okay, calcium is not reabsorbed, and phosphate is not excreted. Because of this vitamin D, low vitamin D and low calcium. So whenever there is a low vitamin D resulting in low calcium, what happens is parathormone secretion increases. When the parathormone secretion increases, parathormone acts on the kidney, but the kidney is not functioning here. So it acts on the bone and releases the calcium, and it increases the calcium release. and it increases the calcium release. So when the calcium is being continuously released from the bone becomes lytic and bone become weak, so resulting in these kind of picture called as rugged jersey spine appearance. So this rugged jersey spine appearance is also seen in osteopetrosis. When there is an renal osteodystrophy or whenever there is a secondary hyperparathyroidism, not only these features are seen in the skull. If you see in the skull, you can see a pepper pot skull. You can see a pepper pot skull. You can see a pepper pot skull in the hand. In the hand, you can see that there is an uh, bone resorption, bone resorption along the along the lateral side, along the lateral side of the middle phalanx. Okay, so bone resorption is seen along the lateral side of the middle phalanx. So these are all certain bony changes which can happen in secondary hyperparathyroidism. So what you need to understand is it is mainly because of the chronic kidney disease where kidney is not functioning, vitamin D synthesis is not happening properly, calcium is low, calcium absorption is low, calcium is not reabsorbed from the kidney, phosphate is retained. All this lead to an increase in parathormone levels. Parathormone cannot act on the kidney because kidney is not functioning, so it acts on the bone repeatedly, resulting in increased calcium release, making the bone weaker and weaker. So this is called as an secondary hyperparathyroidism, secondary to chronic kidney disease, which we simply call as a renal osteodystrophy. Renal osteodystrophy. And what you see here is a rugged jersey spine. What you see here is a rugged jersey spine. Okay. Now, whenever a patient is whenever the patient is severely osteoporotic, they can easily sustain fractures of the vertebra. They can easily sustain fractures of the vertebra. Now, what is osteoporosis? When the T score is less than minus 2.5, we call that as an osteoporosis. So, what is osteoporosis? There are two kinds of scores you can make from a DEXA scan. One is called as a T score, another is called as an Z score. We follow T score commonly. When the T score is less than minus 2.5, we call the patient as osteoporotic. Vertebral fractures are common osteoporotic fractures. Okay, so whenever there is an osteoporotic fractures, the patient presents with you severe pain. The patient present with you severe pain. The patient can present with loss of vertebral height, loss of vertebral height, loss of vertebral height. Okay, so in order to reduce the pain and to regain the height of the vertebra, you can do a procedure called as vertebroplasty procedure. You can do a procedure called as vertebroplasty procedure. How this procedure is done? Okay, I'll just give you a schematic diagram. You can easily understand. This is an collapsed vertebra. This is an collapsed vertebra. We'll take two collapsed vertebras. Okay, we can take two collapsed vertebras. In one vertebra, okay, we put a probe. We put a probe, and we inject a cement here, and we inject a cement here, and we inject a cement here. Okay, and we inject a cement here. In the other condition, in the other patient, a very similar condition, but instead of a probe, what we do is we put a balloon inside the vertebra. We put a balloon inside the vertebra, and inside the balloon, we put the cement material. We put the cement material here. So one side we directly inject the cement into the bone. On the other side, we put a balloon and we inject the cement into the balloon. Okay. So this procedure where we directly inject the cement into the bone is called as an vertebroplasty. On the other end, where we inject the cement into the balloon is called as an kyphoplasty. Is called as what? Kyphoplasty is called as an kyphoplasty. Now, what is the cement which is used here? The cement which is used here is called as an PMMA cement, polymethyl meta acrylate cement. What is the cement which is used here? It is called as an polymethyl meta acrylate cement. Polymethyl meta acrylate cement is used here. Polymethyl meta acrylate cement is used here. Okay, what is the difference between these two? Here we use a balloon, here we don't use a balloon. Now, what is the problem in vertebroplasty? Here the cement can enter the spinal canal. Cement can enter the spinal canal. You all know behind the vertebral body you have got the spinal canal. So this cement can enter the spinal canal. But when you inject the cement through the balloon, the cement is not extruded. Cement extrusion doesn't happen in kyphoplasty. Doesn't happen in kyphoplasty. That is why kyphoplasty is a better procedure than vertebroplasty. So vertebroplasty. Okay. So this is procedure which is used in the treatment of compression fractures, which is used in the treatment of compression fractures. It is used to decrease the pain, used to decrease further collapse. But the problem with vertebroplasty is the cement entering into the spinal canal is a problem in vertebroplasty, which was overcome by the next technique called as kyphoplasty, which was overcome by next technique called as kyphoplasty. So now once they inject the cement into the vertebra which was like a wedge shaped, okay, regains its height, okay, it regains its height. So this is called as vertebroplasty or kyphoplasty. So this is what they are showing in the picture also. Okay, now coming to the next disease. Okay, so here what you see here is uh, is an appearance in the cortex of a femur, appearance in the cortex of the femur, and this appearance is called as an flame shaped appearance, or blade of grass appearance, or blade of grass appearance, blade of grass appearance. Okay, so you know the grass which is like this. So you can see a lytic area in the femoral shaft like this. So this is called as blade of grass appearance, which is seen in a disease called as Paget's disease. Paget's disease is due to an abnormal functioning of the osteoclast. Why Paget's disease occurs? It is due to abnormal functioning of the osteoclast. Abnormal functioning of osteoclast. It is due to abnormal functioning of the osteoclast. Okay, it is due to abnormal functioning of the osteoclast. Now, whenever there is an abnormally functioning osteoclast, okay, the disease goes into three phases. One is called as a lytic phase. Next one is called as a mixed phase. Next one is called as a sclerotic phase. Next one is called as a sclerotic phase. In the lytic phase, there is an increased osteoclastic activity. There is an increased osteoclastic activity, and gradually it goes into sclerotic phase. There will be an increased osteoblastic activity. There will be an increased osteoblastic activity. Okay, these patient can present with certain radiological features. In the skull, they can present with osteoporosis circumscripta or an cotton wool appearance in the skull. Okay, the skull can become enlarged. Okay, and the basal part become flat, which is called as in platybasia. So if you see the skull of the patient with the Paget's disease, the base of the skull becomes thickened. Okay, so the base of the skull becomes thickened. Okay, the base of skull becomes thickened and the basilar part becomes evaginated. Okay, giving a classical a cap like appearance, which is called as an tom o shatter appearance. Tom o shatter appearance. So tom o shatter appearance is called as an, it is a cap. Okay, it is a cap. It is the shape of the cap which is called as an tom o shatter cap appearance. Tom o shatter cap appearance, where there will be thickening of the base of the skull, which is called as in platybasia, and there will be basilar evagination. There will be basilar evagination. Okay, there will be basilar evagination. So there will be basilar evagination. So there will be basilar evagination and there will be platybasia, and this is called as storm o shatter cap appearance, which is a pathognomic sign for Paget's disease. Very, very important. Pathognomic sign for Paget's disease. Pathognomic sign for Paget's disease. Very, very important appearance. Tom O shatter appearance. Tom O shatter appearance. Tom O shatter appearance. Okay. So apart from this, the patient can have a blade of grass or flame shaped appearance. In the spine, they can have a picture frame vertebra. In the spine, they can have a picture frame vertebra. Okay, so all these are important radiological findings in Paget's disease. All these are important radiological findings in Paget's disease. All these are important radiological finding in Paget's disease. Okay, fine. So with this, we'll move to the Next question. Okay, so what X-ray they are given is, again they are giving an X-ray of an a vertebra spine, where you see a bone within a bone appearance. Okay, where you see a bone. Okay, see a bone and within a bone appearance. So whenever you see a bone within a bone appearance, then it goes in more in favor of an osteopetrosis. Osteopetrosis, again, it happens due to defective osteoclast function. Defective osteoclast function. So where there is an decreased carbonic anhydrase, where there is a decreased carbonic anhydrase, where there is a decreased carbonic anhydrase enzyme activity. Okay, so whenever there is a decreased carbonic anhydrase enzymes, okay, so the bone is not lysed. Okay, so remodeling doesn't happen. So remodeling doesn't happen. Okay, so when the remodeling doesn't happen, the bone becomes weak and it is prone for fractures. So it is basically due to an carbonic anhydrase enzyme deficiency or an chloride channel deficiency or an chloride ion pathology. Okay, chloride ion deficiency or chloride ion pathology can lead to osteoclastic dysfunction. So here the bone becomes completely sclerotic, okay, resulting in a classical appearance called as a marble bone disease. So here the bone becomes completely sclerotic, a marble like. So that is why it is called as an marble bone disease. So in the marble bone disease, you will have an endo bone appearance, okay, or a bone within bone appearance. You can have a similar kind of picture here, similar to the secondary osteo or secondary hyperparathyroidism like rugged jersey spine. And here, because of the lack of metaphyseal cutbacks at the osteoclast, if you see the femur, okay, if you see the femur will develop a flask-like appearance like this. Femur will develop a flask-like appearance like this. So this flask-like appearance of the distal femur is called as an Erlenmeyer flask deformity. So this is called as what? Erlenmeyer flask deformity. This is called as an Erlenmeyer flask deformity. So whenever there is a failure of metaphysis cutback by the osteoclast, then it ends up in a deformity called as an Erlenmeyer flask deformity. So osteopetrosis, so there is no medullary cavity. So what happens is, whenever there is no medullary cavity, suppose if there is a fracture which happens in the distal femur or in the femur, okay, you don't have any medullary cavity, so you cannot put any nails within the femur to treat the fracture. So intramedullary nailing intramedullary nailing cannot be done here. Intramedullary nailing cannot be done in the case of osteopetrosis. Intramedullary nailing cannot be done in the case of osteopetrosis. So what you can do is, you can fix the fracture using plates and screws. You can fix the fracture with plates and screws. So the treatment of choice in any fractures in osteopetrosis will be the plate and screw fixation. Plate and screw fixation. Okay, plate and screw fixation. Now I will ask you another question, important question. When there is no medullary cavity, what is actually present within the middle of the bone? What is present within the middle of the bone? So the main structures which are present within the middle of the bone are the hematopoietic tissues. So the patient will not have a proper hematopoiesis, so these patients might require bone marrow transplant. These patient might require bone marrow transplant. Okay, this patient might require bone marrow transplant. Okay, because of the lack of osteoclast activity, the foramina in the skull can get occluded, can result in cranial nerve compressions, can result in cranial nerve compressions. Okay, so if they undergo cranial nerve compression, then it requires neurosurgical decompression. It requires neurosurgical decompression. It requires neurosurgical decompression. Okay, so many things can occur in osteopetrosis, which is also called as a marble bone disease. Remember, Erlenmeyer flask deformity, endobone or bone within bone appearance are examples or classical radiological appearance of osteopetrosis. Osteopetrosis. Okay, why it happens? It happens because of the poor carbonic anhydrase enzyme or the chloride channel defect in osteoclast. Okay. And now, can anybody tell me where do the osteoclast reside in the bone? Can anybody tell me what is the area where the osteoclast reside in the bone called as? Okay, where the osteoclast reside in the bone called as? Yes, yes, in the bone where the osteoclast stay. What is the house for the osteoclast? Where do they stay? Can anybody tell me what is the area? It is not lamellar. It is not lamellar. There is a specific area where the osteoclast goes and sit or osteoclast stays in the bone. Okay, so these areas which uh, osteoclasts are seen are called as an house ships lacunae. They are called as what? House ships lacunae. They are called as house ships lacunae. They are called as house ships lacunae. Very, very important point. Okay, very good, Priya Varshini. Very good. It is the house ships lacunae. It is where the osteoclast goes and reside in the bone. Okay, so in the house ships lacunae only all this HCl secretion, all this chloride secretion happens. So it is an area where the bone remodeling is also seen. So once if these enzymes are not working, the bone is not properly resolved, not properly remodeled, resulting in osteopetrosis, Okay. So with this note, we'll move to the next topic, which is called as an osteogenesis imperfecta, which is called as